Can you connect to Girish? Apollo Bangalore?
Srinivas, can you hear us?
Yeah, they're just connecting. Nice to see you, Girish, and thanks for
Pleasure.
agreeing. And
No,
last batsman, still a lot of people are waiting.
I'll
Thanks.
try and keep your excitement. Thank you.
In the newer innovation session, we thought though it was old technology, but reintroduced by Merrill with a newer Beres stent, many people would
Right.
like to showcase this thing. We have Dr. Ajay, Dr. Anil, Dr. Samir Dani, and many other friends to moderate this case to you. Over to you, Ajay and Anil and Samir. You can go ahead.
Thank you. Thank you, TCT team. It's always been the most comprehensive meeting that happens, covers everything. And I've always had the privilege of kindness from Dr. Srinivas to demonstrate something. But you would ask me, why am I showing this? This looks like a no-brainer. But it's nice to understand a new technology, resurgence of a technology where we think of temporary scaffolding or temporary plaque stabilization and allowing positive remodeling of the vessel. I think that's the therapy of the future for coronaries. Today from Apollo Bangalore, I have the privilege of demonstrating a case. With me are my colleague, Dr. Praneeth, my tech, Ms. Sakaria, and my nurse and OCT team here. So we have a lot of learning in this case. This is a lady who is 67 years old. 10 years ago, she's had a stroke, hypertensive obstructive sleep apnea. And in 2018, she had an acute coronary syndrome and underwent an angioplasty to LAD. Is my screen visible to you all? Is the angio playing?
You are visible, but we don't see any clinical details.
Now we can see it.
Yes, I would come again on the clinical details. 67 years old lady, hypertensive, obese, obstructive sleep apnea, had a stroke 10 years ago. And in 2018, she had an acute coronary syndrome, antral non-ST elevation MI, and had undergone a stent to LAD, and which is working very well till day. For last 3 months, she's had slight crescendo angina. We try to manage her on optimal medical management. She is someone not very active, but still her minimal activities are restricted due to angina specifically, not dyspnea. And her stress echo was positive. And we did an angiography a couple of days ago because we wanted to schedule this procedure for today. Can we play the right? Ejection fraction is normal. This is her right coronary artery. So may I ask for the comments from the chairpersons and expert panels? How does the RCA look like?
The RCA is diseased, Dr. Girish, clearly. What was the stress helium showing?
There was an ischemia on the inferolateral side. Very little, not much. But her symptoms are very disproportionate to what we found on echo, stress echo. Okay, next. Can you go to the, play this, please. Freeze. Yeah. Go.
So I think this is just one really important thing, the importance of the RAO. I can tell you that there's definitely a lot of people who will just shoot LAOs of the right coronary artery, maybe do a cranial, and then go on to the left. And here you can appreciate the eccentricity of the lesion. There was a hint of that on the LAO shots, but here you can certainly see that it looks more severe than that. If there are significant questions, you can always do physiology, et cetera. But I've seen many lesions like this missed because people don't take this shot.
Yeah, another point to be noted here is that there is a sharp angulation. Hi, Girish, this is Anil Dhal.
Hi, Dr. Anil.
So there is a sharp angulation there, and which means that there may be a little calcium somewhere there because one should be prepared for it. So I would not address this without imaging.
Wonderful. We actually did an FFR, and that was 0.82. And then we know today that probably symptoms have a lot more role to play in a person with limited activity because PCI primarily improves quality of life and then reduces the hard endpoints. And the lady, we suggested in medical management, she said, no, doctor, this affects my going to my washrooms and coming back. Then I said, we are missing something. And although FFR was 0.82, we decided to image as Dr. Anil asked for. Can we run? Now, when we do an image,
Let's not forget that FFR is a continuous variable. You know, we've always been hung up on
Yes.
0.75 and 0.80s, but it's
True.
really a continuous variable.
Yeah, I mean, I
Very
think that's a very important point. I mean, the only other thing you could think of is that perhaps, you know, this is both epicardial and microvascular
That's right.
disease.
Some
That-
amount of INOCA
Yeah.
playing in here.
So, but I
Very
think
true.
imaging it to see is very reasonable. And then, you know, you can have a conversation with the patient as well regarding what you see.
Okay. Can you put the imaging on the main screen?
Yeah, we can actually see it nicely. It's,
Actually, it's
Okay,
looking
thank
quite
you.
good here.
we have some very
Oh,
big
wonderful,
screens that Srinivas
wonderful.
has for the meeting.
Yes.
So it's great.
Thank you. Okay. I mean, when we do an imaging, it's very important to understand MLD max. Apart from that, the zones of triluminar healthy segments, because you're not only treating the lesion, but also you're choosing the landing zones. Look at the severity of stenosis. I think it beat most of us when you look at it. Could you go back to the lesion per se? Look at that. Come back up. It's about 1.69 is the minimum luminal area at that point. Go down to where we found that 6.9. Yes, here. Can you see that? And it's significantly fibroatheromatic. Not so much calcium at a 67 years old lady. We may think there must be calcium buried in that fat, but look at that. We went all round. There's very islands of calcium here and there, but significantly fibrotic. Now we are getting into the lesion and coming more proximal. Here, another thing that we must understand, we are not in the, stay there. We are not in the largest of the diameter. Can you just check the length diameter here, please? You'd find it 2.8 or 2.9 at this place. Come in. No, some more, yes. Okay. In the other, mean is about 2.9 is what we found, right? Stop. But the advantage here is you have triluminar structure in the vessel. Now go a little distal, where you have the larger lumen area. If I were to implant a stent by angiography, go down, please. Keep going down. Yeah, stop. A little down. Come back, please. Maybe we would have chosen this spot. Come back, more proximal. More proximal. Yes, stop. Here, can you see? There is no triluminar area. There is little fibrosis, but beyond that, it's all fatty tissue. So at times, it's not just enough to see the largest landing zone, but also a healthy triluminar segment to land. And now let's go to the lesion. You have to look at the
By the way,
MLD.
one of the reasons the FFR may be 0.82 is because as tight as this is, it's very focal in that
Yes.
one area. And so that may be what's going on.
Absolutely. And then here you could see that it's pretty fibrotic, not much calcium, and beyond that is a lot of fat. And go down now, distal. We could either land here or keep going down, please, a little bit. But you don't have a good triluminar area again here. So we just thought if we have an opportunity, let's land it in the right place. Keep going down, keep going down. There again, you have significant fat and quite thin intima. Keep going. Yeah, small island of calcium was there. Go down. This is a good zone, but it's a smaller area. We'll choose a slightly bigger. Yes. We just thought we should choose somewhere at this point. Yeah. Come back proximally, I think. Little. Yeah, I think we chose to do the diameters again. Get me the cutting board. Okay. So
And remember, because this is an RCA without a major branch that's coming off, you actually, as long as there's not a significant amount of plaque here, you can actually use the distal reference to size the stent. So
absolutely
probably 3.0. There's nothing wrong with taking a 2.75 and then going up to 3.0. But in an RCA, at that level of the RCA, it's almost certainly going to be 3.0.
Absolutely. You expect it to be cylindrical tube. And here, we wanted to give her a BRS. The simple reason is, there's no calcium. and she's done very well with the previous stent. Why not? Although she's 65, very focal lesion. So temporary scaffolding is far superior to a permanent metal is what we thought. There is some anomalous origin of the RCA, so we had to use an AL1 and used a guide extension. This is by Medtronic, which telescope, which helps us in terms of, OCT can be visualized inside. Here, since there's a fibrotic tissue, we just thought we'll use a Wolverine. Nothing can be better than this to get you a good cut. Go. 4.
You took a 2.5 or 2.75 or 3.0?
It's a 3.0. Come back. And we know when we use a BRS, you always take it to the largest lumen that you have calculated the size of the BRS. So if the 3.0 is the largest, we will take 3.0 and not 2.75 and try to make it 3.0. That's the way to choose a scaffold.
What was the pressure on cutting balloon?
We went up to 8 atmospheres. Give me that. Okay, this seemed to have, give me OCT back again. Since we have enough time, it's not a complex procedure. So let's just see what Wolverine does. And we will choose a scaffold. The length we have chosen about 24. And look at how differently we implant a BRS compared to a metal scaffold. It's a great, scaffold. I've used Absorb quite a few in the past, but this is much thinner. It gives you good long-term results. I mean, we have had now the OCTs of scaffolds which we had implanted even 1 year ago. Are we ready? First, calibrating. I do with 10 cc syringes, the OCTs. Start, please. Okay. So usually land up using 8 cc. If you have an RCA, we can even do a pure saline OCT. If you wish, I'll show you one. Give me a saline. Well, there's a beautiful lesion where there's no need for contrast, but you will need a little more. 20 cc lever lock, please. Now, can you play the OCT on the main screen? And you can see the plaque modification that has happened. And can we do one more saline OCT if you don't mind? Okay, another study. Wait. Let me tell you. So I washed out all the contrast so that there's no conflict of interest. So now I'm with only saline. You can see, no, keep both angio as well as OCT, please, on the screen so that they know it is a saline OCT. Live? Yeah, calibrate. Start. So here I had to use about 15 cc of saline. And you see the pristine images of saline OCT. Comments from the dais, please.
No, it's a good way of saving contrast. It's much easier in the right corner. It's much easier with a guide extension. You just want to be careful because you can sometimes cause VT. And then also the big question is that the areas and the sizing, you have to adjust it. But you already kind of know based upon the initial run what the size ought to be. And in this case, you're just trying to confirm that you have adequate prep.
Normally, they recommend that we pre-dilate with their own balloon. So give me the balloon, please. although we have a good luminal gain, but still we will follow the protocol. Cuts are good, you can see. Yeah.
Say that again, you're going to pre-dilate again?
You know, you need to follow their mandatory advice. They have given a balloon for pre and post. So I would just go at a very nominal pressure, make sure there's no hematoma, but I would dilate. Because this scaffold compared to absorb, you know, you better have a very good luminal, what do you call, volume, or no resistance to the passage of the scaffold.
Yeah. The only thing is I mean, with the cutting balloon already, you know, you've done quite a good job.
Right.
I just wonder if the protocol is designed, it's cheap, but to
Yes.
sell their own balloon because this is, I mean, a pretty good result.
Very true. I'm just being, you know,
Dogmatic.
prudent.
So you want him to
Maybe
change
the-
from using a BRS to a DEB now and getting away?
No, but if you're going
No.
to use the BRS, I
not.
mean, you don't have the balloon with
Sure.
their
You
balloon.
don't need another
Yeah.
balloon dilatation.
Go. Just 4, 6. You know, sometime the cuts that the the cuts that the Wolverine cause may obstruct the scaffold movement. I've had few instances, many a times, after you do a cutting balloon, it's prudent to do a regular balloon just to make the surface more even. Give me the scaffold, please. 374. Yes. 324 scaffold, please.
This one is a
Now,
non-contact
the one
balloon?
thing I was going to ask is, did you measure the length of the dissection on that last OCT run? Because
Can we
there
just
is a
check
fair
on
amount
the
of diffuse
yes.
disease proximally, and I just worry if 24 is long enough.
Okay, can you just check in the, can you play the OCT on this frame, please? Yeah, good. Now, can you check again the landing zones? Is there any hematoma or cuts anywhere else? No, Maba. Landing zones, does it have any dissection or cuts? No. Keep coming back in proximal. Can you show me? Keep coming back. Where we wanted to land, is that area free of dissection? Go slow, yeah. Good. No extension of the plaque modification where we want to land. So now I am taking the scaffold 30 into 24. Oh,
This is where the co-registration can really help you if you have it up on the screen.
Can you
then
just
know
show the
exactly-
co-registration?
you know
They didn't have the
exactly
privilege of
which
seeing
stent-
co-registration.
This stent marker has to be.
Are you seeing? No, we are not
Yeah,
seeing
no, we can
co-registration
see it.
here.
We can see it.
Okay, thank you. Right, you have a bigger screen. I'm a blind man, very small screen for me. Right, show me, please. Are we where we wanted? Oh, yeah. Okay, can we have one injection? Let me pull my glide extension back. Pressures are better. One cine. Okay, I think this is where we intended to.
Yep.
Okay, go up, please. Very slowly, 2 at a time. 2, wait, count 5 seconds, and then.
All right, great. So now this is deployed. What we're going to do is we have one last talk. And so
Yeah, please
let
go ahead.
you optimize the stent and do an OCT, and then you can come back. Okay.
Thank you.
Thanks
Thank
so
you.
much. And
Come
the
back.
last talk is going to be on CTEF interventions by Dr. Girish. And I'm actually really looking forward to this because this is a procedure that I do and patients get a lot of, satisfaction out of them.
Good,
So
good.
let's see what we got.
Go 6, 8. 6, 8.
Good evening, everybody. This is the last talk, and I'd like to thank the organizers of the TCT South Asia and Dr. Srinivas for having given me this opportunity to speak in this elite forum. Nothing to disclose. So when you look at the management of chronic pulmonary thromboembolism, hypertension, the pulmonary artery tree, as per the Stanford's classification, is divided into 4 levels, 1, 2, 3, and 4. So the surgical domain is level 1 and level 2. Level 3 is for the interventional cardiologist, and level 4, depending on the reachability in certain segments, and of course, medical management. Between level 2 and level 3, it depends on the surgical skill as well as what we can achieve by balloon angioplasty. So let's get into the investigations of CTEPH to understand where balloon pulmonary angioplasty exactly comes in. So we follow the traditional SCAR algorithm, which is suspicion when you suspect a case, echo and VQ scan, confirm with a right heart cath, a pulmonary angiogram in selected cases. Please understand here that it carries a significant risk. So you must be careful when you perform this. If you have a good CT pulmonary angiogram or an MR angiogram, that would do. However, in certain selected cases, a pulmonary angiogram is often mandatory. To assess the risk, we often do hemodynamics. I'll just get into that in a minute. Comorbidities have to be assessed, how sick the patient is and how far down the line the patient is. And we always have a team decision, including the surgeon, to take the final decision as to how we are going to proceed in managing each case. These are the guideline recommendations regarding the investigations. This is just a snapshot to say that echo is the cornerstone, class 1B, right heart cath 1B, VQ scan 1C, CT pulmonary angiogram 1C, routine biochemistry. This is very important to rule out all the comorbidities or associated conditions which can cause pulmonary hypertension. Of course, abdominal ultrasound and pulmonary function tests are also done, 1C recommendation. A chest CT is required as a class 2A level of evidence C recommendation, and a DSA digital subtraction angiogram is also 2A level of evidence C. So these investigations must be done before we do a balloon pulmonary angioplasty procedure. This is the echocardiogram. This is the cornerstone. You can see here that there is a right atrial chamber enlargement, free-flowing TR. We have significant advances in terms of the assessment of the right ventricle, in terms of quantification of the function. We do a grid mapping, we do speckle tracking, we do 3D rendition, all of which can be seen here. This is important because your outcome of your procedure depends on this. The last panel shows free-flowing clots in the right ventricular chamber, and this you should be very careful, or dislodging this may be fatal for the patient. We also do a lung perfusion scan. This is a VQ scan. The panel below shows the complete superimposition of the ventilation and perfusion scan. Important because you need to understand how many segments of the lung are affected so that you can plan management. CT pulmonary angiogram, again, we have a fantastic team who can do a 3D rendition. You can see the second and the third images showing what we call as a 3D spin images. This is important for me as an interventional cardiologist to decide which are the segments that I need to intervene, and also an understanding of the bronchopulmonary segments. An MR pulmonary angiogram may not be required in all cases, but this is corroborative evidence, and in a center of excellence like ours, we use this for many patients so that we understand not only the anatomy, but also the perfusion. And you can see in the panel below, you can see that there is a spectral frame that you're seeing, which is turbulent initially, and this becomes laminar after the procedure. Pulmonary cath and angiogram, right heart study. I told you it's important to understand how far down the line the patient is and to assess the risk, who needs an intervention and how soon. And of course, the pulmonary angiogram, which we already discussed. These are the parameters that we look into. I must say that the treatment of CTEPH is surgery. This is a class 1 level of evidence B recommendation as per the ESC guidelines, 2022 guidelines. Also, balloon pulmonary angioplasty is for selected patients. This also carries a class 1 level of evidence B recommendation. Medical management for the level 4 disease is for all patients. Now, let me, in the last 5 minutes, talk about what is this balloon pulmonary angioplasty for CTEPH. The indications are for inoperable patients, those who cannot be operated because of advanced age, comorbidities, surgically inaccessible or very distal lesions, that is level 3 and level 4, residual lesions post-surgery, or recurrent CTEPH, especially when these patients are inoperable for the second time. we do the pulmonary angiogram and a collateral angiogram. You can see on the panel on the left, this is the collateral angiogram. This is important because many times the patients have massive hemoptysis and you need to act fairly quickly. Especially this patient had a drop in almost 6 grams of hemoglobin before we could identify where the bleeder was. So knowing about this is often handy so that you can save the life of the patient. The angiographic subtypes of CTEPH are the localized type A lesion, the type B or web lesion, the type B subtype 1 is a longitudinal defect, type B subtype 2 is a complex mesh lesion. These are the classical lesions which benefit from intervention. Next up is the more complex lesions, type B or abrupt narrowing, that is a third type of lesion. This is a dangerous lesion because balloon sizing is often difficult, and if you oversize, there's a chance of a rupture of the pulmonary artery which can be fatal on table. The type C subtotal, type D pouch, and type E tortuous. These are lesions that we should stay away from in terms of intervention, at least in the initial part of our program. We also use, in a center of excellence like ours, IVUS, OCT, and angioscopy where necessary, where we need to get more details. Important that I must highlight that the vessel sizing is very difficult, especially when we need to decide what is the size of the balloon that we require. So here, IVUS and OCT are very, very handy because you get the luminal measurement and also the angioscopy, which of course is now no longer done. But since OCT is readily available, as you've seen in the previous cases, this comes in very handy. The hardware we use is a long femoral sheath, guiding sheath, guide wires or atraumatic wires or the B-palm wire, cross-pander balloon, which are atraumatic balloons, and of course, we have gelatin sponge particles, which is a lifesaver when there is a perforation. Simple right femoral access, long sheath. We use oftentimes a right Judkins catheter, 014 floppy guide wire, which is atraumatic, dynamically altered inflation, distally 2 atmospheres and up at 6 atmospheres. And don't do more than 5 to 6 lesions in one sitting, or there is a chance of reperfusion edema and complications. I'll run you through a few cases. This is the first one showing a right upper lobe pulmonary artery occlusion. We used a 320 balloon and you have an excellent result here. This is the second case. This patient was dependent on oxygen with a saturation of 82. We did an intervention. I used a Fielder XT wire, crossed over the lesion, changed it with a B-palm wire, inflated with a 320 balloon, and you can see the mid-lobe artery opens up. This patient, we could get him off oxygen and he's now ambulatory. Case 3, this is from Kenya. This patient came all the way from there. The right, again, the right middle lobe artery occluded, opened it up, serial dilation, and you have an excellent result here. Case 4, a very challenging one, the left lower lobe artery. These are certain special techniques. We used balloon support, which we often use in coronary interventions, and deep inspiration, a very good technique because this straightens up the pulmonary arteries, especially when the patient holds his breath in deep inspiration and then follow up with serial balloon dilatation. You can see that the entire left lower lobe pulmonary artery opens up. The fifth case, again, the right middle lobe lower artery occlusion, again, serial balloon dilatation. This patient has excellent quality of life now and is pursuing an active life. Collateral embolization, as I told you, very important to identify collaterals. This patient had massive hemoptysis. We tried to put in a coil, but since the collateral was very tortuous, we injected TVA particles which shut down the collateral and saved the life of this patient. This oftentimes happens in the middle of the night, so having a knowledge about collaterals is extremely important. Combo procedure, the surgeon does his bit, level 1, level 2, and then we come in and do this. So we started this after a doctor's mother was not improving after surgery, and we followed up by doing a BPA, and then we could get her off ventilator, and the patient is doing fine now. Complications, vascular injury, vascular dissection, allergic reaction to contrast, adverse reactions to anesthesia, lung injury, very important. You can have bleeds, renal dysfunction, and access site problems like hematomas and pseudoaneurysm. For the reperfusion edema, we use a Pepsi score, and this is, important because you need to know where we have to stop. Never overdo a procedure, never overinflate, because what seems to be a small bleed can actually be a torrential bleed, and the patient may collapse even before you realize your patient is really sick. As a rule of thumb, if the patient has hemoptysis, it's time to stop that procedure at that point. Always we have surgical backup and ECMO ready whenever we do these procedures. This is our experience of 30 cases, fantastic results till now. And the future directions, of course, is rotation angiography, Singo iPilot software, and we use a pressure wire. You can see the animation. The beauty of this pressure wire is it can be maneuverable by rotation and gives us an excellent way to negotiate into tortuous pulmonary arteries and also measure the pressure difference between these two segments. Other interventions, Dr. Srinivas asked me to cover the other interventions. So just 3 slides. We do an intraatrial septostomy device. These are still in phase 3 and phase 4 trials. So what we do is we do a balloon septostomy so that we can save the life of this patient whenever they have decompensated. Pulmonary artery denervation. This is a simple way in which the sympathetic nervous system is modified. The panel here shows our first case that we did, a patient who was very sick and too far down the line, underwent a pulmonary endarterectomy procedure, but did not have much benefit. So after this PA denervation, we got down the mean PA pressure by 20 millimeters of mercury, and the patient's doing fine and ambulatory and off oxygen. Percutaneous spot shunt, and this is my last slide. This separates the boys from the men. You can see that this is a case where patient is very sick, and you can see that in our patient, you see here that you actually get into from the descending aorta into the left pulmonary artery and then put in a covered stent there. A very tricky procedure, can be fatal, but your patient is dying anyway. So this is the chance that you need to take, seize the opportunity. And we had a fantastic result. And this boy, who's about 17 years now, is doing very well. This is, again, I'd like to place on record my grateful thanks to my chairman, Dr. Devi Shetty, who helped me to learn this technique. And I trained with Dr. Yamashita in Tokyo Medical College. And I'd express my gratitude to them. Thank you, everybody.
Fantastic. I mean, this is something marvelous. I do not know from where you've collected so many patients. We keep trying to look for getting ideal patients. Fantastic. You've done great work.
We are the largest center for
You
so
would be. I mean, this is great work. Really
Okay.
fantastic experience just to listen to you.
What is that 6.5? You come where it's
Let's go
malapose,
back to the live
6.1.
case
It's still
until we wrap
touching.
up.
I know that Shaolin Chen does a lot of pulmonary denervations apart from doing
6.82. I
decay
think we are okay with that.
So let's see what you have.
Girish,
Okay.
you're back with you.
Thank you, Dr. Anil, and I'll take you back. So go back to the implantation. You saw the scaffold implantation there. We have chosen 324. Congratulations to Dr. Bhagirath. Fantastic cases. Show the implantation, please. Yes.
What is
You
the
can-
strut thickness of this device? Because we can
100 microns. That's why it's called Mirus 100. So it's 100 micron thick. So not as much as absorb though, 150. And you can see here, there's about a millimeter beyond those 3 markers. So compared to absorbs 2, you have 3 markers, so which gives you a good positioning for post dilation too. Next. So after this is the first injection after implantation, freeze. You can see the lesion is where it was severe is probably still slightly under expanded. Next. And mandatorily,
of course, you have to do your stent expansion manually because it doesn't detect the stent.
Absolutely. And here we position the dot on the balloon, post-dilation balloon, between those 3 markers, platinum markers on the scaffold. And this how. And since it's a polymer, you need to keep the inflated post-inflation for much longer. Our practice has been at least for 60 seconds at the nominal pressure that they suggest 12 at the edges. And in the middle of the body, we even go up to 16 for about 60 seconds. So we keep doing that.
And that was with a 3.0 balloon, right?
It's a 3.25. Their pre-dilation balloon for a 3.0 scaffold is 3.0 and post-dilation is 3.25.
They are both non-compliant balloons?
Yes, they are non-compliant balloons.
Yeah, just be careful, if you're going to do this, you want to make sure that the vessel size is adequate to accommodate that. But in this case, it looks like it was, and it probably grew a little bit too.
Yes. Come back, please. Next. And next, please. Yes. Next, last. No, go up to the next inflation. Yes, play that. That's the final inflation. Play next. Right, next, forward. And go forward to OCT. There was a challenge trying to pass because there's a significant change in the angulation and the diameter of the vessel. So I had to make the guide pretty coaxial as though I'm intubating. So I had to bring it back up and then the OCT passes. Next. And this was a saline OCT. Can we just show the OCT, please? Can you play that? Yeah, can you go back to beyond the stent edge? Again, MLD max, you want
it
to
looks
see any
very good,
dissection?
yeah.
Yes.
Just
You look at any dissections? Yes, fantastic. No edge dissection.
and can you just run the OCT?
Keep running the OCT, please.
Just hit play.
Yes. You can see 5.8, 6.2 millimeter squares. Yes, here.
There's that
No,
area. There's a little
little
bit. There's a little bit
calcium.
of calcium there. There's a calcium from
There's a calcium here which is
6,
impeding your
9, 30,
yeah.
10. Yep.
Yes,
as predicted.
yes. Was buried inside that fat. But if you see the diameter, we have achieved almost the same, even in that calcified segment.
And very important to look at the proximal edge of the stent because the OCT was having issues crossing. You want to make sure
Sure.
you didn't disrupt anything there, and it looks pretty. Keep coming back.
Yes, keep coming back. Play the whole length, please.
Yeah, it looks pretty
No
good.
proximal dissections. Keep playing till it
And no
enters the guide.
unloose. Yep. Great. Well, that's fantastic.
Thank you.
Are you going to do one final angiogram and then?
Yes, we should be done. So let me take, there's one small area of, 2 millimeter where it's not as well opposed. I'll just show you. Can you go to that? Just because it's sick, there was a small, I won't call it ectasia or dilated, but an area which is unduly more. Can you go to that area, please? Yes, here. Can you see that? But no point chasing because just
Yeah.
1 millimeter and area is about 6.57, whereas the average area has been about 5.7 to 6.1.
Yep.
Okay. Now,
Great.
one final shot and we should be out.
If you don't mind going to the full, yeah, perfect. That looks great. Well,
Thank
thanks so
you.
much. Really, really appreciate your transmission and concluding the meeting. And thanks again. Great demonstration.
Pleasure.
Right.
Thanks again, team.
Thank you, Girish. We all loved the last presentation too. Excellent demonstration with OCT. The OCT puteness and the way you present also was great. Thank you all. I think we could hold still a significant number of cardiologists till end finally. Thanks to all the faculty like you and all the senior faculty and Dr. Ajay and all who are sitting here. With this, I think we come to end of today's to this year's edition of TCT India South Asia. Can we have that concluding video? Yeah,
Thank you.
coming.
Good night.